Tracker and push it all the way from medial and connect it. So that is one way in which they're like pseudo paralysis because of bicycles, and especially ladies, housewives, and that is not like a very heavy labor. So we have
key problem here looks to me that the rotator intruder release while he was pulling the supraspinatus, it was like that it is not released properly from the LHB and the supraspinatus. So sacrificing LHB is not a
for everything in this literature, but the point well taken by the which is Ravi sir is saying, and clear of the bursa from that posterior aspect also, and at least you could or we are comfortable with the arm pouches. Only arm pouches.
The releasing the nerve in the spinal glanded notch and the supraglanded is still less understood, but there is a good trial is going on. I think it's from the Greece. They are doing a trial.
Without doing any all that malunion of a fracture. If you have to say overhead old and retracted tears, you advise them surgery today, they'll
repair and being a very tight cuff. With the stability of the anchor, taking the second bites for a better visualization. With a movement at the anchor, it shows that we are putting the wrong thread. Right, second bite in the cuff. Sometimes we can even cross the bites in case we feel that we want to look. Now the suture retriever look. Suture retriever. No. Some people prefer to take the knots as they go along, but that way the space keeps on decreasing. More comfort. At this space, so we now put the third anchor, taking more of the posterior most tissue. Suture retriever shall park the threads back. छोड़ने तो ऊपर से आगे निकल जाएगा, गोल ऊपर से आ रहा है तो. Remember, use the ulta. That's. So we just rotate. Chalo. Good. So this is the anterior to posterior and anterior suture pass up. So 4 bites done, the 5th bite going in, looks good to me. I'm happy with the posterior extent of my arm. I feel like you're doing anything good. शोल्डर में 2-3 तो बनती नंबर 2 की फाइबर वायर दे दो फ्री लोड करो इसलिए at the end but somehow I still feel that दोनों साइड से दो दोनों साइड से double bite from underneath to superior aspect of the cuff. Again, a knot there. We need to identify these knots right. जाने ठीक जा रहा है. ठीक है? सबसे posterior weight है. Yes, yeah, okay, sir. Chलिए. What the threads are retrieved. I normally use a SMC knot to your lunchtime over. I'm trying to see what and the first knot I'm taking. Okay. So I'm pass pointing and the first knot goes in place.
जा बाहर रखा गया सारा बाहर उधर मैं अब उधर चेंज कर दूंगा जा बाहर सारा
ऊपर नीचे आ रहा है तो यार कुछ कर पड़ा है वही लेट्स टाई दी सेकंड नॉट होल्ड इट थोड़ा शोल्डर पे करो यार ये थोड़ा
Dr. Siddharth, are you able to hear us?
simple
No tying is left. So we can come to the surgery once the surgery is complete.
I'm enjoying the surgery right now.
Dr. Devendra, is Dr. Devendra Chauhan lecture?
The disaster has struck. The anchor is out of the groove.
In PJ was the Tarun and his colleague Kamal. So both were in 22 ward, and then thanks to the Shivam also, he's a fellow here in the joint. With with other about the long head of biceps, how to mobilize a retracted subscapular steer, and is there any need for corticoplasty or not in the anterior portal and post-op rehabilitation. The clinical presentation, if you look at the patient, once patient is showing the severe limitation of activity with more will be the disability. If you have a subscapularis only, there will be one force couple is lost, whereas we have a combination of other rotator cuff. That is the force which is exerted by the patient. Like any shoulder problem or any orthopedic problem, get the. So also look at the medical condition. What is the status of? You can see the supraspinatus on the top. We can see the long head of biceps in the rotatory interval, but something is missing on the anterior side of the head of humerus. That is probably a subscapular. If you look at the other case on the left, on my left side, where we can see the supraspinatus tear, we can see the tendon retracted here, we can see these things. We can use the LaFosse classification, that what kind of tear it is and how much height of the tendon is, or is it a combination of tear. This is the kind of classification superior border of supraspinatus, long head of biceps, and as we go back, we can see the tear of the supraspinatus. And SCHL, which is and anterior edge, which which we call it as a comma sign. And in the next image, we one most interesting case where we cannot see anything in the front with long head of bicep subluxated pair of the subscapularis. Releasing the long head of bicep is the way I start in all my rotators is so we went into the lateral portal, and that's the way to go in all rotator cuff repair, viewing from the lateral side, the elevator kind of instrument to release it. And here we are releasing from the front, then on the top. And on the picture which we saw initially, there was no subscapularis in front. Now we could able to retract to pull the subscapularis out of the anterior part of the glenoid. Once we have done release the tissues from the undersurface of the coracoid, use the burr, release some amount of the bone from the coracoid to prevent the anterior impingement. Use a suture passer device like Scorpion, or we can do the retrograde suture passing device using a bird beak from the anterior portal. Here we can see the sutures are retracted anteriorly, and we are tying the knot from inferior to repair at the end, and also we can see the repair of the subscapularis. And some part we can expect that these tendinous. So the take home, I will say that assess the patient clinically, how disabled that patient is, and identifies it. If there is any question, I'm happy to answer.
Thank you, Dr. Devinder. Any question for Dr. Devinder? Any question? We will go with the felicitation of the speakers.
Any questions from the audience related to this session?
Hi. Hello.
बैटरी में पहली बेटी गिरा दिया बैटरी डाउन है दी मैं कितना मैं जाना इसने अपने बीच चली गया
एक्चुअली नंबर 5 होता है थोड़ा इसलिए बॉडी वर्क तो तुम्हारे सामने इनका नहीं भरोसा ये टूट जाने का डर लगता है भाई मैं तो नहीं यार वही वाली बात है ना हमारे तो पेशेंट्स होते हैं प्राइवेट प्रैक्टिस नहीं हमारे प्राइवेट प्रैक्टिस वाले पेशेंट होते हैं
Where do you place your anchor? So essentially it's a crescent-shaped lesion that extends from 6:30 going up to around 3 o'clock, just below the MGHL essentially. Exactly is 5:30, 6, 5. So again, that depends on your experience and probably to the extent of your labral tear, right? Where the labral tear is extended on the face. So nowadays, the recommendation is to put anchors on the face around 3 to 4 mm from the edge. So that's where the of anchors. So again, there has been controversy about it. People have talked about putting in 4, 5. I think the most important thing here to consider is the size. So now it has been said that only up to 3, definitely not more than 3 postage stamp fractures, and then they say that putting in, so what they found was that age below 25, your inferior skeletal portal, right, you can establish an anterior portal as well for viewing. And so once you're putting in the anchor, what you will see is that you don't want it too into the center. When you're putting in your anchor, make sure sometimes the tendency is to keep it at a much acuter angle. And then the anchor can skive off. So always make sure a first pass or something like that. I tend to use it underneath it, right up to the tear part. And then you want to, as you pull, this is what happens. When you're pulling in your sutures, they get entangled as. So that's your bumper. That's the kind of bumper you get. Now you can put in another suture. This is the anchor at sacs. It's for engaging off-track lesions. The defect is filled with the tendons of the infraspinatus and teres minor. Again, portal placement here, the center or the medial edge. Ideally, it should be adjacent. Biomechanical studies say that it should be adjacent within the 5 mm of the articular cartilage margin of the hill cephalic to the tendons measure. And 2 middle, as I said, it can cause limitation of your internal rotation. So number, again, a lot of configurations have been divided. Practically 1 center and 3 anchors, 2 medial, 1 lateral. So again, this is a review published. It's a biomechanical study published in beak or a similar device. You can use a bird beak, you can use a Mitech suture retriever. Again, they come in curved, so that helps you with the perimeter search. That's your hill sacs lesion as a viewing for the posterior portal. And then what you'll do is essentially I pass a roughen the area and mark my spot. And then that's again the anchor being passed. So I'll pass my sutures. I'll take 1 inferior and 1 superior. This is done before we start our band cuts. Right? Then you take your sutures, take out the cannula, and now you pierce it using this is the % incidence intraoperatively, and around 4.5% as the mode of with the anchor pull-out. You have patient factors, obviously bone marrow density, osteoporotic patients, there's a higher chances of pull-out, plus the cuff tear size, because obviously otherwise they were too close and cause increased pull-out. Deadman angle, as described by Burkhardt, still holds a gap between the medial and the lateral row. And put your burr in there. Just shave it off gently, and then you insert your anchors. Do not insert too deep. They made different configurations and studied it, which fails. And try to get the anterior anchor. Has to be, you end up with few more portals to help you out with your suture passage and delivery. What I tend to do is I do not use too many cannulas. Practical tip is using maybe a different company anchor when you're using 3 or 4, so that at least the suture color is different at the end of when you're trying to tie them. So avoid confounding and very, very close to the muscular tendinous junction. You have to be through it. You do not want to go in through the muscle substance. You want it through the muscle substance. So to take home, accurate portals are a must. Anchor placement needs to be planned precisely. The type of anchor does not really have a good assistance is something that you cannot replace when you do get shoulder surgery. Thank you very much, and I take this opportunity to invite you all to Sisicon. It's being held in Jaipur in the month of November.
Irreparable cuff tear, superior capsular reconstruction, lower trapezius transfer, and augmentation test.
Good. So, thank you, Dr. Karna, and thank you all my friends and my seniors from BATHINDA who have invited me here. Cuff. So either there is no tendon or there is no muscle. So with all the muscles torn, all the cuff muscles which are gone, and you are not able to pull them back to the footprint. To know that there are different surgical procedures, but what to do and when to do, we should understand the concept of shoulder plane. There are 4 internal rotators, while just 2 external rotators are trying to pull the humeral head externally, which stands for CLEER. So we need to understand when does the patient have ILAE, ILER and CE. So there's some MIRCT and then young female, but the scapula is a solution for these patients. So if the shoulder is functional, painful, and well, So when there is a functional cuff deficient shoulder with pain, so what to do in these patients? It's a non-functional and there's loss of balance. So when there's a loss of vertical balance, only X-rays were done, some injections were given, and she was just managed with some analgesics. But when there was no relief, she wanted to travel all the way back to India to get the treatment done. The humeral joint, I will not say irreparable here, but when we saw the sagittal cuffs, we see there's no muscle at all. Times on MRI, you may see that you may perceive or anticipate that I will be unable to bring this cuff to footprint, but once you start releasing a technical video in which we'll see checking for the reducibility of the cuff, on pulling it, it was not coming on back to the footprint, so I planned of doing a SCR, so you have to clear off your anchor. So as said, to prevent entanglement, either you start marking them or you use a different colored anchors and use different portals to park the sutures. Just don't try to put the anchor, park the sutures, don't hesitate in making an extra portal. So once you are done with this, you have to check the sizes and ask point. So once you have passed the sutures, you can park them 2 incisions in proximal and distal of the thigh. To make a Nevisel portal and the center anchor. Then do some suture passes from the remainder cuff to the follow-up, and she has restored the vertical balance. So, and she was able to do all her activities. So there are high rate of return. There's a lot of studies which have come up from that is possible, and graft to be pushed and pulled inside the joint. It should not be just pulled, and preferably 2 teams of surgeons so that his arms come back in. So basically there are no external rotators. So internal rotation is working. The X-rays look okay. He's a 50 years old army man with a history of fall. It was just coming to the medial edge of the mid part of the humeral. So I plan to do a lower trap SCR with a semi-T graft. So it is harvested as usual. Then looking from the posted by giving a 5 centimeter incision along the spine of scapula, the semi-T is sutured to it. It flips onto the humeral head. So which the knots can be subsequently tied after you pull the graft inside the lengthening of the loop post-operatively. So then this tendon is sutured back to the muscle, whatever possible. So do multiple things to save the shoulder, so that we can preserve the natural joint and get the function back. He was able to hold his arm. The ERS is negative now. So, and he was able to do all these activities, and he was very happy with the outcomes. Shoulder arthroplasty or a bio-RSA, which you have to lateralize the glenoid, or you can do a modified L episcopo type of procedure and the synthetic patch. So it all depends. So they have promised to have a better healing and good initial strength tendon when there is no muscle, there is no good bone, there is no good joint, or there is a superior static migration of the humeral head. When there is a dynamic superior, so when they are trying to pull it and it's superiorly migrated.
This is something which I think is going to be a game biodegradable polymer. It disappears after about a year, and it's a vertical that comes to us. Then this will act as a depressor of the humeral head, and that's how it functions. So it restores your vertical plane stability, but does nothing for you. So just have you mark all these shoulders, and be done. Then we migrate to the subacromial space. And the way we do it is we pull out our trocar and we shift it into the subacromial space, and we'll sweep it and clear out some of this subacromial. Find our graded tuberosity or the edge of the graded tuberosity, and from there we'll go medially, and we go 1 centimeter medial to the glenoid. The minimum subacromial in the path that my balloon is going to enter the shoulder. So as I'm going in over the glenoid, I'm dilating and I'm creating space. So the balloon goes in. And remember, we want to find this black line. The black line must correspond to the edge of the graded. Now sits at the edge of the graded tuberosity. Then we start inflating. So we put in the normal saline, and it will sit snug into this space. So the key with this is you want to overinflate to get the creases out. So we snap it into its final position with this clip system. That means it's deployed for this. They must not be arthritic. They must not be pseudoparalytic. They must have an anterior and a posterior to satisfy the other conditions.
Thank you, Dr. Manat. What's the cost of this procedure?
The arthroscopic transosseous cuff repair. So transosseous has been said to be the bone, and it should be a stable fixation. That's what we were taught in our orthopedic training. To repair the cuff, there is increased blood flow inside the cuff tissue, which increases relative to velocity. The revision, in case if there's a re-tear, it becomes less challenging. There are benefits of arthroscope superior to inferior and medial to lateral, and you can pass multiple ultra high molecular, and then subsequent passes are made into the cuff tissue, and then knotting is being done. So this quote at the laser mark, which is mentioned in this particular jig set or the instrumentation set, then we come up with a jig which goes into this cannula, a silicone cannula or a passport cannula, because it's easier to do on, it's difficult to do on the posterior, it's easier to do on the interior. So as you make the pass, you park it, so that there is no entanglement of the instrument. But here you bring to, you tend to bring knots of tear. So there are different studies which have said there is improvement in the repeat MRI. So they had an identical re-tear rate which was up to around 4%, and the healing results were similar in both the blood. So that's what we repaired it. It was a big tear, so we have to make 2 tunnels and made around 8 passes into the cuff. But it again makes sure things more difficult and more complicated. This is a 6 months MRI, follow-up MRI, and we can see the nice tendon sitting onto the tuberosity, and use a cortical augmentation. Knots very tightly, use our orthopedic biceps to do this. This is going to happen. And you have to be very careful, very gentle with all these tissues. So the take-home message here is, it's a gold standard technique.
Thank you, Dr. Indri, for your presentation.
I think there is the lecture will be after the surgery. Dr. Ansul. Dr. Smith Banerjee, sir, if you are kindly come there. Dr. Vivek Bansal.
To kindly take his lecture on the case discussion on the shoulder instability.
Panel discussion.
Sorry, the panel.
21-year-old boy was working abroad as a computer professional had a single episode of shoulder dislocation around. Let's have a show of hands. People in fear of operative, first time dislocator. A reasonable LSAT lesion. So he went for the different images, confirming the same coronal images. The reports of the MRI that we obtained from and a reasonably moderate LSAT. So, that should stay there. Now he's come for the treatment to you after 3 months of injury. So now, how many people will operate and did an absolutely backyard repair? ND aspirant, expected to be a good physical activity guy. Right shoulder recurrent dislocation, first episode 1 year back during sports. Reduced in emergency without all comfortable. Okay, could be mild fallacious or a. So this is the coronal image of this very patient. Anything different? No. SAG images, we did not decide. I think we made some wrong calculation here. It was actually very minimal loss. CT scan suggestive of simply SAG. 1, 2, 3, 4, we have good. And then there comes the Hagel lesion. Viva ID, he's done this case. So he's not allowed to speak in this one. So you can see that 1, 2, 3, what do you know? Backyard plus open Hagel. Hagel was repaired, and after that the backyard repair was done. So case 3, last one. Green MRI, green backyard. The coronal sections. So along with a small LSAC, very small LSAC. So anybody in case of in this case anything different apart from else happened 6 months later, less than 6 months later. This was the post of X-ray looks good. 6 months later. I have not put the corner section by chance because I had opposite shoulder done 4.5 years back, dislocated again during this. Images, he sent me all those second surgery images. I asked him for the third one. So somehow I had only the X-ray which I had in my own file records. So I'm just telling you the findings. In bone loss was and looks okay. Thank you.
And what we did did a little bit proactive work on the shoulder. As I go through diagnostic roundup, this man had this biceps. Okay, fine. It's a straight. Can you appreciate this?
Yes, sir. We can see
this one, and upper side is another. I'll show you from other portal. Once we first we will this step and. Can you appreciate and comment just cleaning the Virsa, scapular Virsa, thickened part?
Good morning by Dr. Maheshwari, a young chap, 25 years old, has a drop-arm sign, almost pseudo paralysis.
And we will fix this from.
So your intralateral portal is it within the interval? Yes.
Yes, great. And we will use this portal for putting anchors and a little bit yes, spider of the arm to get more space anterior. One.
Rajiv, which anchor do you plan here?
student. We saw.
We just struggle with the old.
And now I am just almost down. Inbox, and I am now switching. This no. Yes, I am changing my wheel portal. I find it too crowded here. Dr. Hemant, what you do here if subscap is upper 130 here, then you go from the posterior portal, or it's a complete clear, then it's a inbox type, out of box type of repair? Dr. Vaishram.
So, yes, sir. Yeah. Okay. So, I think when it comes to subscap, 90% of the subscap operators which may require more time, so I want to finish off out of the box.
Second back, please.
Part and go where the meat of the
Straight, got you. Okay. जो हमने टिश्यू से पास लगा वो कौन सा था? Let me check. You're right. Good. Good. Two threads we have passed through the subscap. Okay, fine. And now. Say again?
Would you still put two anchors looking at the room and amount of
Give it 9 right now. Take it out.
This is the word peak you're using, sir?
This is suture.
Yeah,
Take it out.
looks good.
Take it out. Just wait. Other one. Pull. Okay, fine. Okay. No, stop.
Put it in tight.
सही नहीं है दूसरा चीज है कुछ दे दो आप जो भी है yes.
Yeah, you can switch something. Is a second.
One.
Looks like the anchor is showing up.
Take it out.
Is here. Dr. Nitish Kapil, Akash, all delegates and faculty are invited for the gala dinner at 8 p.m. at Sepal Hotel.
कैमरा है कुर्सी के नाल ला दे एक दूसरे ने बंदे ने नौजी टक्कर नहीं ना आपका मैं तो ड्रेस लेंदा नहीं मैं तो डिगे तो फाली करी हम बंद करते हैं आधा घंटे का ब्रेक है आधे घंटे
ये लाइव है भाई। नहीं नहीं मैं लाइव कर रहे हैं भाई, नाल नाल वीडियो रिकॉर्डिंग भी चली जाती है यूट्यूब।